2021 and going forward, this is the best time to be a pathologist for sure.
Dr. Siba El Hussein, how are you doing, my friend?
I'm good. How are you?
I am good. Excited to chat with you again tonight, live with an audience, talking about hematopathology, cytopathology, some interesting visual kind of specialties that hopefully we can get some students interested in for the future.
Yeah.
One of the favorite questions that we have here is, what is bread and butter for hematopathology?
CLL, SLL.
Yeah. What is that? So CLL.
So chronic lymphocytic leukemia, small lymphocytic lymphoma.
Mm-hmm.
This is the most common adult lymphoma, and this is one of the most common things that we see in our practice.
Yeah. Mm-hmm. And lymphoma, talk about that for the students who don't understand lymphoma. They haven't heard that before. What is that?
So lymphoma is a neoplastic process that involves lymphocytes among other cells, right? So when there's a neoplastic process that involves epithelial cells, we call it carcinoma. Mm-hmm. When it involves like anything that has to do with mesenchymal cells, we call it sarcoma. And then when it involves lymphocytes, it's called lymphoma.
Lymphoma. So we got cancer,
mm-hmm.
the dreaded cancer. Yep. Have we seen, specifically for you, with what you're doing mostly with lymphoma, the hematopathology world, are we seeing more of it because there is more of it, or are we seeing more of it because we're just better at diagnosing?
That's a great question. We're definitely seeing more of it, but just because we're getting better at diagnosing stuff at an early level too. Especially with NGS, next generation sequencing, and all the flow cytometry advanced stuff, we a lot of time do those testing for other malignancies, and then we pick up small clones that we think these are pre-stage or like a precursor to full-blown lymphoma. And this is why a lot of time we diagnose, for example, something called monoclonal B-cell lymphocytosis, which is a precursor of CLL. We diagnose it in people before it becomes a real CLL.
Yeah.
So we're definitely very good. We're getting better and better at this.
Getting better. Talk about the next generation sequencing. Every time I talk to pathologists, it seems like NGS is like what everyone wants to talk about. Why is this such a big player in the pathology world right now?
Well, because it's very sensitive and it's very, very cost effective. So you're able to, run a little amount of tissue and run multiple, test for multiple genes in one assay. So imagine that in one machine, you can run up to 20, even more, 20 samples from different people and run multiple testing for multiple genes in a very specific way and in a very cost-effective way. So this is why we like it. And NGS changed a lot of things, especially in hempath, because a lot of classifications got better because we kind of like found specific mutations to specific neoplasms. So now when we see these mutations, we know that we're dealing with this specific kind of neoplasms, and it's not subjective anymore based on what we're seeing morphologically. So now we have like an evidence that there's clonality and the specific mutation is there, and we're more confident when we say this is what we think it is.
Yeah. For next generation sequencing, is it sequencing the whole genome that it can possibly go, or are you throwing the alphabet at it and you're saying look for LMNOP?
Exactly. So it's a targeted sequencing. So we have a panel for example, in hematopathology, let's say we think we're dealing with a myeloid neoplasm like CML or ET or polycythemia vera, right? So these are myeloid neoplasms. Myeloproliferative neoplasms. So we run an assay that targets genes that are known to be affected in these kind of neoplasms. So it's very targeted. We know that, for example, we're gonna most of the time or a lot of time we detect A, B, C, and D. So we run these assays for these specific genes. It's definitely not like a whole genome sequencing.
Yeah. So as the hematopathologist, are you interacting mostly with physicians or with patients?
So most of the time we interact with oncologists. Because most of the time, especially during tumor boards, we rarely interact with patients. However, in my cytopathology practice, I interact with patients all the time because I do the FNAs. I do the fine needle aspirations with the ultrasound. So this is half of my practice.
So let's talk. A lot of people are saying we're way over their head. We jumped right into the weeds, and that's my fault because we've chatted before. Yeah. So let's go back to the basics. Let's talk about how you the training path to become a hematopathologist and what you're doing day in and day out.
Okay, so how I become a hematopathologist. So first, you want to be a pathologist, right? So pathology, for those who are new to this or who are not very familiar to it, is a specialty where you diagnose certain diseases based on the examination of morphologic examination. And now with NGS, PCR, flow, there are a lot of ancillary testing that we use that are very, very helpful for us to make a final diagnosis. So in a nutshell, we're diagnosticians. Let's put it this way, right? So for hematopathology, it's specifically a subspecialty that deals with everything hematolymphoid. So I'm talking about lymph nodes, spleens, bone marrows, and peripheral blood, right? So we do that a lot. So we basically, diagnose lymphomas and anything that has to do with the myeloproliferative world, in the myeloproliferative world. So leukemias, CMLs, all this, kind of stuff as well.
What does your day in and day out look like?
So as I said before, I do both hematopathology and cytopathology. But let's focus on hematopathology, and it's going to be the topic of my discussion today as well.
Okay.
So in hematopathology practice, it depends on where you're practicing. So for example, in where I'm practicing now, there are weeks where I'm only diagnosing tissues, meaning I receive lymph node biopsies, excisional and fine needle, core needle biopsies. So when I receive this tissue, I do the morphologic examination. I order stains on the tissue. I also do the flow cytometry analysis on the tissue, and if I need to send it for molecular, I do that as well. So all of this is for lymph nodes. And then when I'm doing the second week, which is the bone marrow examination week, and this is where we call it the leukemia week because this is where we get, most of the patients are leukemia patients. So we receive bone marrow biopsies for leukemias and other kind of chronic myeloproliferative neoplasms like CML, right? And a lot of time we also receive post-transplant bone marrows for people who had leukemia and underwent bone marrow transplant. And then the clinicians the oncologists are really interested in seeing if there's residual disease or not. And this really affects the response and the prognosis of patients. So this is the second week, basically. So either tissues or bone marrows and blood. Yeah.
Interesting. All right, let's jump into some presentation stuff. I know the students love seeing all of the slides and all of the tissue samples. So go ahead and share your screen again.
So I hope that you can see, and I'm using a platform called Path Presenter. This is something cool about pathology, by the way. It's going digital, and it's very helpful because with time, I predict, and a lot of people are predicting that we're going to be able to do everything remotely. So it's not going to happen within the next couple of years, but eventually it's going to be all remotely done, and you're able to see your tissues from anywhere at home, or sometimes some people send me stuff for consultation, and it's really a slide that is projected online, like on one of these platforms, like the one that I'm using right now. So it's very, very convenient, and it's very helpful for us to use. So the topic of the day, the topic that I chose today, is to show you guys a couple of lymph node tissue that kind of harbor two kind of neoplasms. So the story here is that the oncologist suspected that there's a process, neoplastic process that was going on, and then the hematopathologist, on the other hand, detected another kind of process. So in addition to the one that was initially suspected, we detected another process, or a third process. So now the patient is ended up having 2 or 3 diseases in total. And the reason why I'm doing this is just to show you the importance of, the importance of pathologists, and how can they add to the diagnosis, how can they add to the management and treatment. So let's start by this tissue. This is a lymph node tissue, and some of you might already recognize this kind of follicular shaped structures. So you can see it, for example, over here. I hope, Ryan, you can see my arrow, right?
Yep.
Yeah. So you can see over here that there are a lot of round structures that we call follicles. But once you move around, the picture changes a little bit, right? Like you start seeing those follicles becoming bigger and bigger, and in some areas they become really diffuse, like sheets of cells, right? So let's go on higher power and see the small follicles over here.
That's amazing.
Yeah. So these follicles, however, are not super. They're not normal follicles. They're not really benign. So one reason why I'm saying this is because normal follicles have a germinal center in the center normally, and the germinal centers have bigger cells, and then there are some smaller cells in the surrounding them. And here we don't see this, right? Like we have a small ball of cells and everything look alike. So this is neoplastic. Once you see something, a cell, a population of cell that is kind of like everything looks alike, it's probably clonal, right? And this is what we see here. So all of these cells look alike. We call them centrocytes. And I'm not gonna, go into details in here. I'm just gonna keep it simple. This is a low-grade follicular lymphoma. Some of you have heard of this term before. One of the most common kind of lymphomas in adults. It can be, it can present in a low-grade fashion, and sometimes it can present in a higher-grade fashion. So the cool thing about this case is that this patient was known to have follicular lymphoma. We knew about this diagnosis, okay? And the reason why the lymph node was biopsied is because this patient was diagnosed with low-grade follicular lymphoma a couple of years ago, had treatment with R-CHOP, and then at some point he presented with this enlarged lymph nodes that was, had a high was PET avid, right? So this is why this lymph node was excised, and the reason the clinicians really were thinking about residual, some sort of relapse in this case. However, the interesting thing about this case is that the original lymphoma is only a portion of this lymph node, and then all of the rest is a different kind of process. So now let's jump to this portion over here. So
I see a Sharpie marker.
Right. Yeah. So this is a slide, like a physical glass slide that was scanned. And this is why it has some marking on it. These are pathologists who already looked at it, and they divided it into two parts, right? So now we have this part over here where we think we have a different kind of lymphoma, and then another part over here where we think we have another kind of processes. So now we're ending up with three kind of processes in one slide, and we started with one diagnosis, right? So let's go over here, and over here you don't see those follicles anymore, right? Like the picture is kind of different. The cells the architecture is kind of diffused, and when you go on higher power, everything that you're seeing here are cells that are dying. We call them apoptosis. The process is called apoptosis. So the cells are dying, and then the cells themselves have this higher grade look. We call them centroblast, and I'm not going to go into details on this part, but this is diffuse large B-cell lymphoma. So we had a low-grade lymphoma over here. Let me go back. Okay, so we had a low-grade lymphoma over here that kind of transformed into a diffuse large B-cell lymphoma, which is a higher grade. Okay, so this requires a more aggressive treatment. But the story doesn't end here. So now when we go see the pathologist kind of divided into this, two section. When you go to this area over here, all right. So
it's like an infomercial. It's like, but wait, there's more.
Exactly. So now the cells are very different. So let's focus on one cell, and I think I can make the point over here. So for example, this one cell, right? We have the nucleus, the nucleolus, and then this cell has a lot of pink cytoplasm. All right, so pick any other cell next to it. For example, this one, it has a lot of cytoplasm. I'm not gonna bore you with the terminology here. This ended up being one of those histiocytic sarcomas, which is one of those aggressive diseases. They derive from histiocytes. So the end result of this case, this is what we kind of like did clonality testing on the 3 components. So on this component over here, the low-grade lymphoma that we knew the patient had. On this component over here, the diffuse large B-cell lymphoma that we think is a transformation from the low-grade one. And then on the sarcoma, the histiocytic sarcoma, which is a different kind of diseases. Like we're not talking about lymphomas anymore, right? So we did the clonality testing, and apparently all of them are clonally related, meaning that the low-grade transformed into a diffuse large B-cell lymphoma, and then there was something called transdifferentiation into another lineage. And this is what happened over here. So this is a very rare case, but it emphasizes the role that we can play as diagnosticians. We started with one diagnosis, and then we ended up having 3 diagnoses. 2 of them are very high grade and change the management of the patients.
How lucky is this patient that you just happened to biopsy the right lymph node and got the right slice to be able to see all of this together?
Yeah. This is an excellent point. A lot of time, the surgeon really feels lymph node, feels that it's hard, and it's bigger than the ones that are next to it. So he chooses to take it out, right, and leaves other lymph nodes behind. And sometimes the lymph node that gets excised is not the one that harbors the real money, the stuff that are bad. In this case, absolutely, we and the patients got lucky that we were able to pick up the right lymph node with all the processes that we think are happening inside his body, basically.
Wow.
Yep. So let me just jump to another one. So it's gonna be within the same theme. I hope I'm not being it's not too much for this session, and I hope I'm keeping it simple for people to follow.
That's right. They got to learn. It looks like you're on a website.
Yeah.
Is this your website that other students can check out?
So it's not my website, but it's an account that I have. The website is called Medium. It's a website where you can publish stuff. So yeah, I'll give you my account, and absolutely, I publish cases over there for people who are interested with digital slides, so they can go and play with the slides and go on Zoom. Everything is explained. So I think it's very helpful for people who are interested in hematopathology in particular.
Yeah, I just posted it for people.
Okay. Let me just go. Let me see if I can find a similar one here. All right. So you probably read the title of this one. So composite mantle cell lymphoma and follicular lymphoma. So this is the page of the website, right? And I take screenshots of the cases, and I explain what's going on. Wow. Just like what I'm doing right now, but in a written manner. And then when you scroll down at the end, you'll find a link to the digital slide with the number of the case, and then some suggested articles.
Wow, that's awesome.
All right, so let's go to this one. And this is case 5. All right, so this case, the title gave it away. So composite mantle cell lymphoma and follicular lymphoma, and now that you saw the first case, right, you can recognize the follicularity over here. So we're dealing with the same kind of lymphoma that we saw at the beginning in the first case, follicular lymphoma, and it's called like this because it kind of mimics follicles in benign lymph nodes, and this is what we see here. So little follicles here and there. But again, this is a patient who was known to have follicular lymphoma. He kind of presented with suddenly enlarged lymph nodes. They wanted to see if there's another process that is going on, and this is why excision was recommended. And now on excision, this is an excisional lymph node. We have 2 pieces, one that looks very follicular-like, and then the other one looks a little bit different, right? So here we don't see a lot of follicles. We see a diffuse. This is what we call a diffuse process, meaning that we can't really pinpoint an architecture over here, maybe there's some follicularity over here, but in this piece in particular, the architecture is really gone, and we're dealing with a diffuse process, really. So let's go to the follicular lymphoma one, and we'll go over the architecture over here. So, all right. So let's talk a little bit about the components in this follicular lymphoma. So it's basically formed by these small lymphocytes that we call centrocytes. And notice that everything look alike, right? Kind of look alike. Like the cells are very, very similar. And on the other hand, so let's go to the other component. So now it's very different, right? So there's a component, some processing artifact that we're seeing. So the white areas, the clefts, are really artifacts. They're not real. They're caused by the way we process tissue. So ignore the white in the background. Just focus on the cells. The cells are kind of different as well from the ones that we just saw. However, they're still very, they look alike. They're very monotonous. They're also small to medium sized, right? Like they're not very big. The reason why I'm saying this is because when, the lymphomas are really divided broadly into, when we're talking about B-cell lymphomas, into, small, low-grade indolent type of B-cell lymphomas like CLL, like follicular lymphomas. And the other type is the large B-cell lymphoma, the most common one being diffuse large B-cell lymphoma. So this is why the size of the cells is very important at the initial assessment. So when we're initially doing the assessment of the tissue, we look at the size of the cell, and this can give us a hint as to, what is the nature of the lymphoma that we're dealing with. And then we order stains and molecular testing based on that initial feel that we got from seeing the slides. So now, if I'm looking at it for the first time, these are small to medium-sized cells. I'm not worried about the diffuse large B-cell lymphoma process, but I need to rule out other kind of stuff. And it looks very different from, say, this area over here, the follicular lymphoma area, right? The cells are quite different.
Is it very common to have a patient come in with known follicular lymphoma? Is it relatively common for them to progress into these different cancers just because of the nature of cancer?
No, it's not. So yeah, that's a great question. So most of the time, the follicular lymphoma that present are low grade, and they stay low grade. A lot of time, the patient is doing well, and he or she have a low grade follicular lymphoma. They don't even have treatment. They're just they kept under surveillance for a while, and oncologists assess if there's any transformation or any progression based on regular PET CT scans. And this is the case here, right? Like we start with a low grade. Maybe there was an enlargement of lymph nodes on physical exam or on CT scans. Maybe there was an uptake on PET, and this is what triggered this kind of workup. So in this case, I don't have stains to show to you over here, but this turned out to be something that we call mantle cell lymphoma. And this kind of lymphoma is interesting because it has a specific translocation. The translocation is 1114, and this is one of the scenarios where FISH, like an ancillary testing that is called FISH, is important to do over here so that we can pick up this kind of translocations in this cell. And this translocation is specific for this kind of lymphoma. So without the translocation, we don't diagnose mantle cell lymphoma. And that was the case here. We suspected it based on morphology and some immunostains that we did. And then we did FISH, and we confirmed that there's a component of mantle cell lymphoma, which, everything is different. The management is different. Everything is different, right? So the patient ended up having the low grade and a mantle cell, new de novo mantle cell lymphoma process happening in his lymph node. And this is probably why there was a sense of, progression on PET or on physical exam. The clinical picture was not indolent anymore. There was something going on, and we kind of gave the answer based on tissue assessment.
Can you talk for a second, just going back to the basics, the H&E stain like this, what the different parts of the cell that's causing more uptake or less uptake for the darker, lighter purple?
Absolutely. So H&E is great because each component of so H&E goes for hematoxylin and eosin, right? So each component stains one part of the cell differently. So the H, the hematoxylin, stains the pink stuff, right, the cytoplasm, and then the eosin stains the blue stuff, the nuclei, and the all the details that you can see. I cannot go on higher power, but know that under a real microscope we can. Okay, this is not the highest power that we can see, but for the platform is kind of limited over here. But bear with me. So everything that is blue is stained by eosin, and it helps us see the details of the nuclei. So for example, like if you see the cell that I'm pointing at, you can see like some little dots, black or blue dots. So these dots are nuclear details that we're able to see it based on the stains. And by the way, the stain is very, very old. I'm talking 100 years old, and we're still using it, and it still works like magic. So this is one of those technologies that were invented very, very long time ago and are still doing a great, great job. Even in modern times, we're still relying on them, and we haven't changed to another stain.
That's awesome.
Yep. So let's move on. Hopefully, I can squeeze in some other cases. And if you guys have any questions, just either leave them till the end or type them in the chat box, and hopefully we'll be able to answer them. Okay. All right, this one should be interesting. Another case where hematopathologist also found, the morphologic assessment was very, very helpful in managing the case. So I mentioned before that CLL is the most common B-cell lymphoma in adults. It's a low-grade lymphoma. A lot of time people do not die of CLL. They die of another kind of disease. This is like in the vast majority of the time. I'm talking about 90% of the times, or 95% of the time. However, in those 5% of patients, there are 5 to 10% of patients who develop something that we call transformation, and it's specifically called Richter's transformation. I don't know if you guys have heard of this term before. You might have heard of it, in the future, because this disease is quite common. So Richter's transformation happens in those 10% of CLL patients that are unlucky enough to undergo, to have their disease undergo a bad transformation. So the transformation, I'm going to show it to you right now. This is one of those cases where the patient was known to have CLL. He was, under surveillance. Everything was okay. And then after probably like 10 years, he started having this new onset lymphadenopathy with, a PET avid picture lymph nodes. So we got a small biopsy. And I wanted to, for those who are going to become interventional radiologists who are online with us today, this is what you're going to give hematopathologists in the future. And I beg you to give us more. Right? So this is a core needle biopsy done by an interventional radiologist. So basically, the radiologist look at the scan, identify a lymph node, and then go inside the lymph node and get us a core. Okay, and this is everything we're gonna get, and we're supposed to be able to tell the truth based on the small, amount of tissue. This is in comparison to, for example, this one. This is an excisional biopsy. This is the whole lymph node out, right? The whole picture is in front of you. You can't go wrong. You can cut it as much as you want, right? You have a lot of material to work with. However, with this kind of tissue, you have to be very, very careful, because you are going to, to do a section for your H&E, and then you're going to do a couple of sections for your immunostains, right? And then if you suspect something, you're going to send a section for FISH or cytogenetics and flow. So a lot of tissue is being exhausted, and then a lot of time we end up losing tissue, and by the time we get to the real answer, a lot of time we don't have any tissue left. And if there's anything in the future that comes up, we can't, go back to a bank of tissue that we have. We're going to have to, the patient, unfortunately, will have to undergo the same procedure again. So this is why, it is very recommended to, since the radiologist is there, right? Like to take a couple, more course so that we have something left for additional or future testing. So that was my rant for future radiologists.
Give us more, please.
Yeah, exactly.
And and when you send stuff to the pathologists in general, don't just say, tell me what this is. You need to give a lot of details about what you're thinking about, where it's from, blah, blah, blah.
Absolutely. I think you've been talking with a lot of pathologists for you to say this.
Yes. I am not a pathologist, but I am friends enough with many of them and understand their frustrations. Well, a lot
of time, for example, like this core needle, I will get like a requisition form where the clinical history is lymphadenopathy, and that's it. Right. So this can mean a lot of things, but it's our job to go into the chart and take a look at the previous. So in this case, I knew that the patient has had a long history of CLL for 10 years, and there was suspicion of something going on, and they just wanted to confirm it. By the way, Richter transformation, like the management, the treatment is very, very aggressive. So once we say this word, it's no joke. The patient's gonna, is going to undergo a very intensive chemotherapy regimen. So we have to be sure, and we have to really be strict about what we're saying here. It's a very, very important diagnosis, and unfortunately patients die between a year to 3 years tops when they get this diagnosis. So far the treatment is not very helpful. Oncologists do their best, but they haven't really discovered a real, regimen that can prolong people's lives once they transform. So going back to the tissue, so I guess like if you stare hardly or hard enough at this piece of tissue, you can kind of detect two populations. So the first population is over here, and it's composed of small cells, like little dots. And then you have another population over here, right next to it, right? Like the neighbor that you don't want to meet. So, these are the bad neighbors, and they're bigger, right? Like let me go on higher power. So I'm talking about small cells over here. Look at this nucleus, super small, and then compare it to this one, right? So if we focus over here, this is the patient's known CLL. Okay, so this is how his CLL looked like for 10 years. Everything's okay. It looks indolent, right? It doesn't look that bad. And then when you go and compare it to the neighbor, look at these cells. They look aggressive. They're like these cells on steroids, right? Like they're plump and big and very aggressive looking. So let's take a look.
Ready to attack.
Exactly. And I hope you can sense the difference. I'm just hoping that I can find a mitotic figure. So these high, large B cell. So this is what I was talking about, right? Like this is a small, CLL is a small lymphoma, small cell lymphoma, and it transformed into a large B cell lymphoma. This is a diffuse large B cell lymphoma transforming from a CLL, from an indolent disease. Okay, so these, this kind of large lymphomas, like a lot of time, we're able to detect mitosis very, very easily. Meaning, so when I say this, it means that the lymphoma is proliferating, the proliferation rate is very high, to the point that when we section the lymph node and stain it, we're able to capture multiple cells that were proliferating, and they were in mitosis. And this is how why we're able to detect a lot of mitosis in large B-cell lymphomas. So not very convincing, but this is probably one. You can see that, it's a band. These are the chromosomes that are, aligning to undergo mitosis. Let me see. Here's another one. So I don't know if you guys remember, this is called metaphase, right? Like when the chromosomes align in the center, and then the telophase is when the chromosomes just go to opposite poles of the cells, right? So far I'm just detecting, I'm detecting these. And then the background, a lot of the cells in the background, like for example here, when you see this kind of pink cell with like a very pycnotic or small nucleus, this is a dying cell. So basically, this that died. So again, in the high grade or large B-cell lymphomas, there are two processes that we're able to see: mitosis, because the cells are proliferating like crazy, and then because they're proliferating and there's a lot of time there's not enough blood supply in the background, and the cells are proliferating a lot. A lot of these cells die in the process because they're not getting a lot of supply, right? They're overgrowing the microenvironment where they're where they're at. So you see a lot of apoptotic bodies. This is what we call them, basically just dying cells. A lot of these are dying cells over here. And this is a mitosis right there. So this is this is the best one that I've seen so far. And again, you can see there's a line right in the middle, and these are the chromosomes that are aligning at the center of the cell. And then the next step is for them to go to opposite poles and have the cell divide into two cells. All right. So that's
interesting.
I think I can squeeze like maybe one or two more cases, and we'll wrap it up and see if people have questions.
Let's do one more, and then we'll bring some students on. There was a lot of people. I lowered everyone's hands, so just okay. I'll request hands to be raised in a minute for everyone.
All right, this is a very sneaky one. And by the way, like those cases that I'm showing are not like right now, I'm very familiar with them, and a lot of them have been discussed in something that we call tumor boards. These are conferences where pathologists, oncologists, radiologists meet to discuss certain cases that are controversial or where there are a lot of question marks, and oncologists need real answers and confident answers in order to initiate a certain chemotherapy regimen or other type of managements. So all of these cases were not really straightforward cases. A lot of them were running around for a while until we figured out what was happening, and this is one of the reasons why I'm putting them, I'm publishing them for my fellow hematopathologists and my residents and people that we teach to kind of bring awareness to these kind of pitfalls. All right, so this is supposed to be case 4. So again, I'm not going to bore you a lot with the terminology or the disease type. It's it's not the focus of this session. And if you decide to be a hematopathologist, you'll have plenty of time to indulge in weird names that we have. But the point here is to just be careful at what you're seeing. A lot of times, so there's a saying that we say in pathology in general, and it's the following: never, ever, ever stop at one diagnosis. We even have a hashtag for it on Twitter. Never stop at one diagnosis. A lot of fun. You'll be surprised if you decide to work hard on a case. You'll find stuff for sure, stuff that are hidden, or a lot of time. Well, the majority of the times, what you find is not significant. It's good to document it for future references, but in a subset, in let's say 5 to 10% of the times, you find stuff that are meaningful, just like in this case, where patients get treatment for something that was, unnoticed for a while and was hidden, sneaky, right? And the case that I'm going to show right now is one of those cases. So again, this is an excisional biopsy. This is the whole lymph node. This is the generous surgeon who gave us a whole lymph node for us to work on. And on low power, you can immediately kind of notice that there's like a vague follicularity, right? Like some vague follicles that we can see. So with time, like once you get a lot of experience, when you see this vague follicularity, you start having a differential in your head of kind of lymphomas that do this. Okay, so now I obviously know the diagnosis in here, and I'm going to jump ahead and tell you that was a T-cell lymphoma. that happens to have a kind of follicularity. This kind of lymphoma is called angioimmunoblastic lymphoma. Everything that I showed you before was B-cell lymphoma, and now I'm showing you a T-cell lymphoma, right? So it's a different kind of, it's a different world. So let's go on higher power. And this kind of lymphoma is known to have this vague follicles. If you go on higher power, another characteristic of this kind of lymphoma is are two things. First of all, is that it's it has a lot of vessels. It's very vascularized, right? These are RBCs, red blood cells that have, are traveling in the tissue at this point. Or I'm gonna find you some vessels. Let me see over here. Well, before I find some more vessels, the other characteristic of this lymphoma is that it has a lot of eosinophils. All the pink stuff that you're seeing in the background are eosinophils, and it's also another indicator that whenever we see this, and these are the vessels that I'm talking about. Whenever we see this kind of picture, so we have lymphocytes in the background that kind of look alike. They kind of have like a moderate amount of cytoplasm. You can see like some of them have some like little amount of cytoplasm versus other lymphocytes that do not have. They have a very scant amount of cytoplasm. And then the second thing are these vessels that we're seeing. So you see this line. This is a blood vessel over here as well. And these blood vessels characteristically have a plump endothelial lining. These are the endothelial cells that are lining the vessels, and they're plump, and this is another characteristic of this disease. And then the eosinophils in the background. So these three components help us think about angioimmunoblastic T-cell lymphoma. So we do the appropriate stains, we do flow cytometry, and we kind of like have our ways to prove it. And that was the case here. So that was the final diagnosis, okay? But that was not it. And the other component that I'm going to show you is really sneaky. And, I would say if you show this to 100 pathologists, my guess would be 90 or 95% of them would miss, and these are experienced ones, would miss the component that I'm going to show you. So the thing that I'm talking about is right over here at the edges. So if you look at this slide, right, like everything looks vaguely follicular, but then at the edges, there are darker areas, like here, and here, and here. And obviously, when you have the elephant in the room, no one's going to pay attention, right? Unless like you're being very obsessive compulsive and you're looking at every inch of the biopsy, you'll pick them up. But when you have this process and you're happy with yourself that you made the diagnosis, it's very easy to overlook the small stuff. So let's go over here and see what's going on. So in I'm going on higher power, and you can start to see that these cells are smaller and they're very different from the process that is here. You can, there's a contrast, right? Like there's a sharp contrast between this area and this area. And now let's go on higher power. And what do we got here? Small lymphocytes, very similar to the one that I just showed you from before, the CLL ones, right? Like they're small little dots, very benign looking, but very monotonous as well, right? So these are monoclonal cells, and these are CLL cells right at the edge. They're squeezed by the T-cell lymphoma in the center. And then if you go over here, you can see another focus of CLL right at the edge that is also squeezed by this T-cell lymphoma that is, the predominant population in this lymph node, again over here. So let me show you with stains. I think it's more cool. So this is a stain that is called CD5. CD5 stains for T cells, right? And this is why a lot of, the majority of the cells on the slide are staining. Let me go on higher power. So you can see that the T-cell lymphoma is staining with CD5. All right, and let me show you CD20. CD20 is a B-cell marker, right? So since we're dealing with a T-cell lymphoma, we're not expecting to see a lot of staining over here. What's staining, on the other hand, in the background are benign B cells. So these are the normal inhabitants of the lymph node that were kind of pushed out of their houses, and now we have a foreign, T-cell lymphoma that is taken over the place, and now the B cells that resided in the lymph node are now scattered all over the place because there's an invader, which are which is the T-cell lymphoma, right? So these are just benign B cells. But if you go to that area that I showed you, which is right here and right here, those B cells are sticking together, right? So remember that CLL is a B-cell lymphoma, so it is going to stain with CD20. And this is what we're seeing here. So those B cells are the CLL cells, in contrast to the ones that we're seeing in the background. The ones that we're seeing in the background are probably benign ones. This is a small focus of CLL detected in a lymph node here as well. So now the patient is, ended up having a B-cell lymphoma and a T-cell lymphoma, right? And, if this was not picked up, it would have picked up in the future, where, at a point where the CLL became the predominant cancer in the body, with, multiple lymph nodes and whatnot. But at this point, we detected this component while it was still kind of like localized and focal. And obviously, this is a chance for the patient to be managed ahead of time before this kind of cancer becomes full-blown and unstoppable. Let's go back to the CD5. So one thing that is interesting about CLL is that it apparently expresses CD5. Okay, so CD5 is a T cell marker. It doesn't stain benign B cells, but in the case of CLL, B cells in CLL stains for CD5, and it's aberrant. It's something that is acquired by those neoplastic B cells. And now, if you go to those foci of CLL, you can see that these B cells are also co-expressing CD5. So they're expressing CD20 and CD5, a combination that is very, very telling for CLL. So now let's go on lower power again, just for you to appreciate. These are the CLL components. And this is CD20 again. The CLL is here. And I'm going to go to the H&E again and show you. This is the CLL. And that was obviously captured by H&E alone. So kudos to whomever saw it, right? And it was proved by IHC. And then obviously we did something called flow cytometry analysis, where we kind of like immunophenotype the cells, and we can, say with certainty that we have two clones, a B cell clone and T cell clone, and we can give phenotypes of those populations.
Wow.
Yep.
That's awesome. All right, let's bring on some students. If you want to come on and ask a question, you can for a couple minutes we have. Let's go ahead and you want to turn off your screen share? All right, it'll take a couple seconds. Just to confirm the training path, 4 years for anatomic and clinical pathology, and then 1 to 2 years depending on the specific fellowship that you're doing.
Yeah.
Okay.
So
and then
some people end up doing but the minority of them choose to do AP only, and this is 3 years. If they do CP, clinical pathology only, is 3 years. If you do them combined, it's 4 years.
Okay. Amy, hello.
Hey, can you hear me?
Yep.
Okay, cool. So my question revolves around the advancement in technology as it relates to your field. So from when you first started to now, how has the imaging technology helped your ability to read these? Because I know looking at slides in the microscope in undergrad, we don't get to see the cells in this great of detail. So I was just wondering how that has advanced and how you see it advancing in future years.
Excellent question. And it has evolved tremendously from the time I was a medical student until now. So when I was a medical student, I looked at those really bad microscopes. I had all the bad microscopes to push me away from doing pathology. All of them were in my way. But now the microscopes are getting better. But that's not it. We have the digital platforms that are very helpful. The ones that I'm using right now are very helpful. And again, and I said it at the beginning, these are very convenient for us. We can diagnose at any time, anywhere. people can consult online. While in Uber, I can look at the platform and see what my friend is asking me about. I can go into details. The platform that I'm using right now doesn't allow you to go on higher power, but there are others that are, more performant. So to answer your question, the technology is evolving in a very, very rapid way, and we're only getting better and better at, what we're doing. And, the infrastructure is only getting better with time, for sure. This is like 2021 and going forward, this is the best time to be a pathologist, for sure. Like 50 years ago, I would have never, I think whoever became a pathologist 50 years ago, that was a bad choice. But now we have all the technology in the world to do a lot of cool things. So now is the time, if anything.
Okay, awesome.
What is the concern, if any, for, I know Google is very big into machine learning and artificial intelligence around scanning these digital images and not necessarily replacing, but helping pathologists do their job. So maybe in the future, instead of needing 100 pathologists, we only need 50. What does that look like in the future?
Bring it on, please. Yeah, I'm one of those people who are involved in AI and machine learning in pathology, and we've talked about this, Brian, before, right? So I'm very involved in this, and I'm such an advocate for this to be mainstream in the future. No one's job is gonna disappear. Our jobs are gonna morph into something new that is more cool with AI, like everything else, right? So I don't think being afraid is the right way of thinking about this stuff. Pathology is a very visual thing, and everything that is visual is amenable to AI and deep learning and whatnot. So if anything, we're one of those specialties who are that are going to undergo this kind of transformation very soon, but to our benefit for sure. So I'm going to give you an example, and I'm working on one of those projects, right? So it's a CLL project, just like the small lymphoma that I'm showing you, with a transformation into large B-cell lymphoma. So with the help of machine learning and deep learning, we're able to detect morphological patterns that as human beings, we're not able to see with our naked eyes. And those patterns that we're detecting are able to predict underlying biologic molecular stuff that, if you can predict them with machine learning, at some point you're not gonna, you don't have to do testing anymore. So you see when you run those slides and the machine tells you that, there's this pattern that I detected, and, I noticed with time that when this pattern is there, there's this translocation. So now you're confident that, this patient has this translocation without running the molecular test, right? So it's a very fast, it's very, very helpful. I have very high hopes for this, to help us become even more efficient, even more helpful in the future. So again, for those, AI junkies, if there are any hearing us, this is a field that is going to be adopted. It's already adopted by AI, but AI is going to be the mainstream very, very soon. So for whomever who likes to code or, to do this kind of, machine learning recognition kind of things, this is the field to go to, for sure.
Hey.
Yeah.
Shane, last question. Hello there.
Hi, how's it going?
Hey.
So I had a question about kind of like your day-to-day workflow. I was wondering a little bit about how much you do with like the data heavy stuff, flow cytometry, NGS, like you were talking about, versus how much time do you spend looking under the microscope doing the kind of more judgment-based, like looking for physical characteristics as opposed to quantitative methods?
Right. Yeah. Excellent question. So they go hand in hand, right? So I'm going to walk you through a case. So I have a case with me, and I'm looking at the microscope. I'm seeing patterns. I'm seeing, certain morphologic and architectural, patterns or images. So immediately I have a differential in my head. I immediately open my computer and look at the flow cytometry analysis that is most of the time already ready for me to see. So I can see, if there's a monoclonal population, what kind of immunophenotype I'm dealing with. So I can correlate live between my microscope and my flow cytometry, and then decide if I want to send the tissue for FISH or for NGS or for cytogenetics or PCR. So those kind of testing take longer, 2 days up to 2 weeks to come back. But using the flow and the H&E that I have with some immunostains, I can release a preliminary diagnosis and then say with a comment that I'm doing ancillary testing, and once they're back, I'm going to give you a final diagnosis. And this is what ends up happening every day. So I release preliminary diagnosis every day that I'm confident about, and then after 2 weeks, I just update using, depending on the NGS results or the FISH results, I just update my report and send out a final one.
So then the initial qualitative stuff informs other questions that you're asking. Is that what you're saying?
Say that again?
So your initial qualitative, kind of the flow cytometry and the slides, you inform the later stuff that you do.
Absolutely, yeah.
Cool. Thank you.
Thanks, Shane. Dr. Siba El Hussein, thank you so much for taking some more time with me. I left a note on the top of the chat if you want to hear more about cytopathology, hematopathology. Specialtystories.com/175 was the podcast episode that we did together. I think we nerded out on AI and machine learning, all that fun stuff, a little bit more there. So go listen to that. Thank you so much for joining me and spending some time with everyone here.
You're welcome.
Everyone have a wonderful night. We'll see you next week. Bye.
Bye.